asked during the meals to fill out additional applications for your additional seat credit. I just want you to be aware of that. The other thing is, we have 1 minute. I'm going to take a minute. Who in this room has come the furthest to attend this conference? I actually looked at the registration list, and we are going to give a gift certificate to the Lippincott booksellers, or in the exhibit area, have generously provided a gift certificate for their books. There is a person in the room from Bundoora, Australia. Is that person here? Is that person here who traveled 10,100 miles? No? No? All right, well, you have to be present to collect the gift certificate. So the next one on the list is Alice Lake here from Hong Kong. No? Oh, they're going to be really upset. They're going to be really upset. No? All right, the next one, I actually calculated the distance. I'm not going to belabor this. The next one on the list was Waris Qidwai from Pakistan, Karachi. Very exciting, very exciting. Every year we have more and more folks from everywhere and from all over the United States. And now it gives me very great pleasure to introduce my friend, Dr. Ivy Alexander, who is a professor of nursing at Yale University School of Nursing. She's director of the Adult Gerontological Family and Women's Health NP specialty, nurse practitioner, midlife women's health consultant at Yale. Trained at Penn State, got her master's at Northeastern and her PhD from the University of Connecticut. Her clinical, scholarly, and research interests are in midlife women's health care. She has worked extensively with menopause and osteoporosis management, has published and presented widely. Her work has been translated into Spanish, Greek, and Italian. She's PI on multiple studies. She's another rock star, Dr. Alexander.
Except the allergies here in Washington are like killing me. Is anybody in my boat? I've like lost my voice. Let's find my water just in case. So I'm going to give you kind of a whirlwind tour about menopause. And what's happening really that's sort of new and interesting and exciting in our field is all of the data that's coming out in relationship to hormone therapy and who's okay to take it and how long do we keep them on it and when do we start it. So I'm going to give you a real quick picture on common problems, sort of how do we manage those, but then really spend a little bit of time looking at that data with you. I've consulted or written or done whatever with these people, and I would hope that we'll be able to talk about common symptoms that women experience related to menopause, differentiate the risks and benefits for various different therapies, and then really apply the evidence to develop some management plans. So as you all know, the physiologic changes in the natural menopause transition are variable. You get women who come in that are having their period sooner or later or longer or shorter. And we have various differences that happen in the endocrinologic shift, which really attributes to why some women are experiencing these symptoms. Diagnosis of menopause, just to really remember, we have to really keep a broad perspective. Just because she's between the ages of 48 and 55 and comes in with classic symptoms doesn't mean she doesn't also have cardiac disease or thyroid disease or depression or other really important clinical problems that we need to co-manage with things that might be common. We really don't do FSH testing anymore because the levels are so variable, it's really not reliable. So we really look at symptomatology and time since her last period, using our clinical expertise to make sure that we've ruled out other common comorbidities. Despite all of this, people come to my office feeling itchy, bitchy, sweaty, sleepy, bloated, forgetful, and sometimes kind of psycho. And so then I get to try to help them. Management for selective symptoms. I'm really going to talk today about sleep, GU changes in sex or the lack of it, memory and cognition, and vasomotor symptoms, because these are kind of the top four most classic areas. So the approach really is a stepped approach. We try to look at evaluating risks, which I'll talk to you about briefly, especially related to hormone therapy. And then we talk about lifestyle strategies, complementary therapies that might be helpful, and then potential pharmacotherapeutics. So starting with sleep, It's really important for us to always remember that there are a multitude of different things that relate to sleep. Really, a lot of them are related to hot flashes. It could be interfering with nighttime sleep. So some of the basics are to keep the room cool. I recommend to women to use the fan all the time. You can read some of this, but there was a very funny episode of Judge Judy. Has anybody heard of her? Maybe not some of the people from, where did I hear, Australia and Pakistan and other places, but she's a funny judge that does it on TV, and there were two women that were partners that came on, and one had menopause symptoms and one didn't. And they were fighting about the temperature in the bedroom. And at the end of the day, Judge Judy said, you can put more clothes on, she can't take anything else off, so leave her alone. So, you know, this is real symptoms. It does cause a lot of distress for people, and it seems ridiculous, but it's something we have to pay attention to. Sometimes we get into sleep retraining for women that have early awakening, where we have them sleep only those hours that they're really sleeping well and then back that time up slowly. I'm not going to get into every detail of some of these different strategies because we do have limited time. It's important to realize that a lot of women use complementary therapy, so always ask them about what they might be taking just in case. We do know that estrogen helps with sleep. It helps to decrease sleep latency so women fall asleep faster, and it does increase REM and deep sleep so women wake up feeling better rested after the fact. It may also help to alleviate certain symptoms of sleep apnea, which becomes important related to cardiovascular disease. So fast forwarding to GU changes in sexual health. This is one of the things that really will affect 100% of women. But importantly, not 100% of women are bothered. So again, our clinical history becomes so critically important that we really talk to women about what's bothering them and what they might be doing about it. It's different physiologic changes that happen with aging. It takes longer for women to lubricate. They have less lubrication when it comes. The elasticity decreases. Sometimes they have a decrease in lactobacilli, which will increase the pH and vulnerability to urogenital pathogens. At the same time, women oftentimes experience a decrease in libido. They might have decrease in response to sexual stimulation. This leads to decrease in sexual activity. Oftentimes they have vaginal dyspareunia. We have to always think about the partner too, whether it's a male partner or a female partner, that's a big effect. So when you're thinking about sex, you have to kind of think about the big picture. Women's feelings towards their partner really are kind of the trump, and Demerstein's work has been very powerful in that. So this gal says, honey, what we're looking for ain't in any damn pocketbook. Sexual dysfunction in women, the really complicated thing about this, I did some consulting for Pfizer many years ago when they were looking at the use of Viagra in women. And I said to them up front, you know, the problem is that this drug is all about increasing blood supply to the genitals, which will help a certain population of women having problems, but it's a very complex thing. It involves relationships, desire, arousal, there's orgasmic difficulties, there's pain disorders, and it's mediated by so many different factors. So I came in as a consultant, they spent lots and lots of money. And then they came back to me about 3 years later and said, yeah, you were right, it didn't work. So we have all these women with symptoms. Now this is so interesting. The women are depicted in red and the men are depicted in blue. Experience pain during sex, more women than men. Sex is not pleasurable, more women than men. Can't achieve orgasm, more women than men. Weren't interested in sex, more women than men. Anxiety about performance, more men than women. That's sort of funny. Climax too early, definitely the men. Men were unable to keep an erection, or women who had trouble lubricating. In almost every marker that's like a functional issue, women are having more difficulty than men. And we have how many meds to help women with sexual difficulty? And how many for boys? So we're kind of outnumbered here. Sometimes we cause problems. I always say to the partners, are you sure she's okay with this? So management strategy, sex therapy, and couples therapy, I always put it first. I cannot tell you how important it is. So many women show up in my office and say, well, you know, he wants to do this, he wants to do that, it doesn't feel good. And I say, you know what felt good when you were 20-something, 30-something, even 40-something may not feel good when you're 50-something, 60-something, 70-something. But telling your partner that in a way that you both feel good about and that somebody doesn't feel like they got a bad report card is really hard to do. And also remember that relationship issues are all tied up in how women respond. Lubricants and moisturizers, I'll go over those quickly, and hormone therapy, which is approved for vaginal dryness, but it's actually off-label use for sexual dysfunction. And people that have roles like mine, we use it all the time. So lubricants and moisturizers, we recommend over-the-counter water-based lubricants. Those are short-acting, and those are things that we encourage people to do whenever anything is going inside the vagina. It could be partners, it could be toys, it doesn't matter, but anything that goes inside. When they're using, having discomfort with walking or sitting or just kind of being around, the long-acting moisturizers might help. That doesn't mean that they also still need to use water-based lubricants for anything that's going inside. And a lot of women use both. Sometimes that's not enough, and so local vaginal estrogen is a great option. In that case, I have a couple slides for you. The two exceptions to the no oil rule are vitamin E oil and olive oil. Those are safe to use inside the vagina. Low-dose vaginal estrogen will also help with urogenital symptoms. It improves dryness, dyspareunia, and atrophy, but it improves all levels of urodynamic testing. So for women who are experiencing a little bit of urinary leakage and small amount of urinary symptoms, local estrogen might be helpful, whereas systemic estrogen theoretically and possibly could increase their symptoms. So when you look at the vaginal epithelium, you can see on the left-hand side of this slide that the deep tissues are available there and the intermediate tissues are available, but there are very few of the superficial tissues available. And those are the ones that will really produce the lubrication when a woman is interested in sexual activity. On the right-hand side, a biopsy of the same area of tissue, and you can see that nice proliferative top level. I bet this is a pointer. Yay. That will show you up here how this is really kind of puffed up, so that when something comes inside, it's going to be much more comfortable for her, and she can lubricate a little bit better. As I said, Dennerstein's work has really demonstrated to us that relationship factors will trump hormones. And this was a study that was done in Australia with 438 women around midlife. They were still menstruating at baseline. They looked at hormone levels and all kinds of different factors. And at the end of the day, their testosterone level and their ability to enjoy sex really were not related. What was the important relationship piece there was their relationship with their partner. Despite that, when we've done clinical trials and treated some women with estrogen plus testosterone and other women with estrogen alone, there are better sexual desire scores in the women who are taking testosterone. There are increased numbers of total satisfying sexual activities happening in women who are also treated with testosterone, and there is a decrease in personal distress. So even though the sort of community results show us that hormone levels aren't necessarily the cause of these problems, it looks like when we do treat women with testosterone, it seems to help them a little bit. So this one says, I was on hormone replacement for 2 years before I realized that what I really needed was steam replacement. So still remember that relationship is the key for women in sex. So memory and cognition. Remember that when you are having difficulty remembering things or difficulty sort of thinking through and processing things, that it is often related to sleep difficulties. How many people have had little people up awake at night, or older parents that you were caring for, or cramming for a test and then just kind of bombed it the next day, because you really need that good night's sleep in order to have higher level thinking. One of the things that we have to keep in mind too is that stress is a very powerful mediator, and it's important for us to always pay attention to that in relationship to memory changes that women may experience. Excuse me. The other thing to keep in mind is that forgetfulness among men and women is actually about identical at midlife. We talk about it a lot more women, you know, it's a menopause moment, it's sort of politically correct to say that, and men don't have the opportunity to say that, they just have to kind of fake it, I guess. So it's important to realize it's not all about menopause, and it's not necessarily hormonally mediated, even though we have some good data that suggests that hormones for women benefit mental functioning. So this is just a graph that shows us this is a study that included both men and women, and you can see that things taper off a little bit over time, and this is normal with age and age-related changes. Some of the management strategies that we have are making sure the person is sleeping well, using memory age, lists are really good. I love the iPhone now because there's about 10 different apps that you can have to like talk to yourself or give yourself a quick list or monthly reminders, whatever it's going to be. So we're all getting into different ways that can help out. Really pay attention to own mental acuity. I keep giving my parents little games that have, like the word Sudoku or the math Sudoku or the finding games or whatever, and they say, you want us to play these with the kids? I'm like, no, they're just for you. Can't hurt, right? Use your calendar. So some of those things sound basic, but again, we always try to build on what's happening first. You're getting enough sleep, or you're doing things to keep your mind active, and then we kind of step up to the next levels. Also remember that certain types of memory problems are normal. You walk into a room and you think, what am I doing here? I'm sure that I'm the only person in the audience that this ever happens to, right? So that's totally normal. If you meet somebody on the street and you can't think of their name and you're thinking, I hope they don't say my name because I can't say their name, that's also totally normal. Where you get into a problem is when you meet this person and you think that you really know who they are and you never can remember their name. And it's gone. That's a whole different level of concern, and we evaluate that very differently than people who say, you know, I'm in this meeting, I was supposed to bring something up, I had 3 points, I can only think of 2, but 2 days later you say, oh yeah, of course, this is what I wanted to say. And you're not in the anxiety situation of the high-pressure meeting, you've had a good night's sleep, and of course it comes back to you. That's where lists become critical. Hormone therapy might help. It does seem to benefit sleep a little bit, and we have some data that shows that it's helpful with synapses, but some of the data from the Women's Health Initiative memory study was contrary to that, so let me go through that with you quickly. Some of the basic research, bench research, shows us that estrogen improves neurotransmission and cerebral blood flow. It also helps to improve neuronal outgrowth, as well as formation of synapse in the brain so that messages can come back and forth. This is a slide that shows us on the left-hand side a SPECT scan of a woman's brain during a hot flash. And those brown areas and tan areas are areas of lower blood supply. When you look on the right-hand side, you can see, brown is better and tan is worse. On the right-hand side, you can see there's less brown, there's more brown, which is what we want to see, and a little bit of white, which is good, and that's after this woman had been treated with estrogen for a while. So it seems to make a difference about blood flow, but we don't yet have data to tell us whether there's truly a causative link or not. We had some early studies that showed us that estrogen therapy and hormone therapy users performed better than non-users on memory tests and certain cognitive function tests. And we also know that as women age, it will increase blood flow to the cerebral and the hippocampal brain structures that are involved with memory. We saw in some observational studies that it may prevent Alzheimer's disease, especially if it's taken early on. So the Gerontology Research Center demonstrated that hormone therapy improved verbal learning and memory tests. And the Cache County study showed us that women's increased risk of developing dementia disappeared if they were treated with hormone therapy for 10 years or more when it started at baseline, which is time of becoming postmenopausal. However, the WIMS data, which we will go through a little bit more specifically, the Women's Health Initiative, that this is older women, average age of 63, who were treated, and the intent of this study, the WHI, as you know, was for cardiac prevention. I'm going to go through that with you. But in the memory study piece, it looked like it might increase the risk for probable dementia, and it didn't seem to change mild cognitive impairment. So we have some confusing information on observational studies versus clinical trials about kind of what was beneficial or not. There's a question about a critical window. We're going to talk more about timing with hormone therapy in a couple of minutes. The US HMO study showed a 26% decrease in risk for dementia when hormone therapy was used right at the time of menopause, but there was almost a 50% increased risk when it was used later in life. So this might be the key to helping us kind of create that bridge between observational studies where women start hormone therapy in order to manage symptoms right at the time that they're experiencing the most, right around menopause, versus when we're looking at trials that might have been started a little bit later in life for other purposes. So vasomotor symptoms, which is everybody's favorite reason to come see me. We do know that there are some differences based on ethnicity. This one study indicated that Black women tend to experience and report hot flashes the most, followed by Hispanic, Caucasian, and then Asian women. We also know that hot flashes could continue for a long time, although they usually clump right here around postmenopause, those first 5 to 7 years. See, these are the women that I see, 26 years later, 40 years later, they don't know what to do. The vasomotor cascade, don't you just love this slide? It's so descriptive. Night sweats mess up sleep patterns, cause people to be fatigued, irritability, mood changes. I know nobody in here has ever experienced it. Remember that it happens to men as well, but women get to count it as related to the menopause transition problems, often because night sweats are related to hot flashes and vasomotor instability. I always remind my patients that hot flashes in and of themselves are harmless. I talk to them a little bit about the thermoneutral zone and how your body is used to keeping the core temperature in a very tight range. And as you age, that tight range gets even littler. So if you go too high or too low, it causes troubles. That's one of the reasons that having fans around and about are really important. There's some studies that have actually suggested hot flashes might be helpful. These are a couple studies that I pulled together. There was a decrease in breast cancer in women that experienced hot flashes. There was a decrease in stroke and a suggestion of a decrease in death. Cardiovascular disease looked like it was to the left of the line, but it didn't show statistically significant difference. And I separated these just because this was a odds ratio study and this was a hazard ratio study. So some of the management strategies that we do, we talk about complementary alternative medicine. I'll go through this with you really quickly. And non-hormonal medications and medications. So diet, you want to have your patients avoiding caffeine. It can be a trigger. Avoiding alcohol can be a trigger. Some women find that sugar is a trigger. Increased water just to keep them healthy and feeling good. Stress management is really important. We've got a good amount of studies that show us that regular frequency aerobic exercise actually decreases hot flashes. Everybody's heard about using breathable fabrics and layers. Fans are really important because it helps to keep away those hot spots in the room. Some relaxation techniques have showed benefit, paced respirations. Acupuncture is kind of questionable. The mindfulness program didn't actually change the frequency of hot flashes, but it changed the bother from hot flashes and reduced stress. Paced respirations that have been studied in research settings really use complicated and elaborate monitoring. But we found that yoga breathing, inspiring over the count of 4, holding your breath for the count of 7, letting it out slowly over the count of 9, is actually effective. I wonder if it's more of a stress mediation than anything else, but if it works, I'll take it. There's some acupuncture has been looked at. I did a case review of 8 studies published in the early 2000s, and there's really contradictory evidence. A more recent study showed us that acupuncture and venlafaxine are probably about equally effective. Part of the problem is that we can't get most insurers to cover acupuncture for women, but it is relaxing, and if they have also comorbid stress or pain management issues, it might be beneficial for them. Phytoestrogens, probably not helpful. There's lots of studies out there. Everybody's reaching for this to make a benefit, but in most instances, not effective. Cohosh is probably the best of the complementary therapies that we have, but in its case also lots of contradictory evidence. Ginseng, not effective. Dong Quai, really not effective. Oil of evening primrose has a role in women's health, but not so much in menopause care. Some of the non-hormonal medications that we do use with benefit are SSRIs or SNRIs. Most of that research has been done in breast cancer survivors, but it does show a decrease and it is statistically significant. Gabapentin I use a lot in my practice, but I try to keep it really low doses to start and then bounce it up very slowly because the somnolent side effects can be difficult. Estrogen therapy and estrogen with progestin therapy really do help to decrease hot flashes, and they're probably the most effective option that we have out there. So looking at some of the history that exists in hormone therapy, this is the timeline. It's in your handout. I'm going to go through the most important recent pieces, looking at the HERS trial and the Women's Health Initiative. So hormone therapy and heart disease, in the early 90s, Grady et al. Published a meta-analysis. And this is kind of what prompted some of the companies to go to the FDA and say, we'd really like to look at estrogen as a cardiopreventive medication in healthy women. And they said, yeah, we kind of agree with you. There's a lot of powerful observational evidence, but we should probably have the trials just because, we're in the 90s and this is where the current research is. So there were 2 trials that were designed, and these were designed as statin trials, which is important for us to think about. The first trial was to look at secondary prevention of heart disease, coronary heart disease, and the second was for primary prevention, and those are the HERS and WHI trials together. So the HERS study looked at almost 3,000 women who had existing coronary heart disease, and the idea was to see if treating some of them with estrogen and progestin would decrease the likelihood of them having a secondary event. And we were kind of surprised to see in that first year that the secondary events were higher in women treated. Over the rest of the 4 years of the study, that switched, and then the couple years of follow-up study, things leveled off to show no change or benefit over time. Some people at that point started to say, well, we need to look at transdermal therapy. And the Papworth phase study was 255 postmenopausal women, and they were randomized to 17 beta-estradiol transdermal, with or without an ETA. And unfortunately, their results were really very similar to the HERS trial. So then we looked at the Women's Health Initiative, and this is a trial of over 16,000 women, and there were several different arms. I'm going to talk about estrogen-progestin arm and the estrogen-only arms. In this trial, all-cause mortality was not affected by either estrogen alone or estrogen with progestin, and this slide compares the WHI as well as the HERS data. There's some gap hypothesis that's now coming along, and some of the question is that estrogen therapy and estrogen-progestin therapy might make a difference in risk factors for breast cancer. Let me back up for a second. Breast cancer risk was increased in the WHI in women who took estrogen plus progestin therapy, and was decreased in the WHI in women who took estrogen therapy alone. Then after that, we got results from the Million Women study in Britain, and what showed here was that women who had taken estrogen within the first 5 years of menopause had an increased risk of breast cancer, and women who took estrogen after that 5-year period had a decreased risk or no change in breast cancer. So now there's this question about, well, should we just wait and try to limp through those first few years post-menopause and then start hormone therapy, or should we not? There was reanalysis of the WHI estrogen-only arm data, and it really demonstrated for us that risk analysis becomes important. So I was talking to you earlier about thinking about risks in your patient, especially as related to hormone therapy. Heart disease risk, we're not talking about hypertension here. We're talking about coronary heart disease. We're not talking about obesity. We're talking about established coronary heart disease. And if women have strong family risk factors for breast cancer, those things need to be taken into account. If the woman was at low risk for breast cancer, there was no change in her risk over time with estrogen therapy use. And in the 10.7-year follow-up data that's been published by LaCroix and colleagues, there was actually a 23% decreased risk of invasive breast cancer in women who had treated with estrogen therapy who had been on therapy for an average of 5.1 years. There were no significant effects overall for heart disease, DVT, which my colleague just spoke about, cardiovascular disease, hip fracture, colon cancer, or total mortality. So the beneficial effect of heart disease, breast cancer reduction remained, and the rest of the potential risks were not. And this is with estrogen therapy alone. With estrogen-progestin therapy, the risk did not continue to increase, but there was a demonstration of a greater number who had node-positive cancer, and there was a trend toward increased mortality. We have to keep in mind that risk factors are really important. I just mentioned to you that women who had low risk for breast cancer at the beginning of the study did not demonstrate an increase over time. And so this one compares some of the different risk factors. Family history here with 2 numbers. This is elevated BMI. This is just plain obesity. This is a family history with 1 member. This is age at menarche being I can't read it from the side, delayed, sorry. This is for lack of exercise, hormone therapy use for 5 years, smoking, alcohol use, and then risk is decreased with premature menopause or with osteoporosis. So this is just to compare breast cancer risks and some of the other primary cardiac prevention trials. This looks at statin trials. 7 increased incidence over 10,000 women years. 2 increased incidence over 10,000 women years as compared with the estrogen-progestin arm, 9 increased incidence over 10,000 women years, or in the estrogen-only arm, -8. So it's kind of interesting to see when we look at other statin trials, some of those numbers are the same. In the NAMS 2012 hormone statement, they mentioned that risk increases with women and estrogen-progestin therapy use, but in fact, risk increases for all these problems as women age as well. So the latest epidemiological news on breast cancer data shows us that there was a decreased incidence in 2002 after WHI happened. The incidence rose again in 2005 and 2006. And so we started to wonder, because at the same time, hormone therapy prescriptions continued to stay low, and in fact have gone lower, and some of the data from Canada have really shown us that. So it's really helping us to try to question, is it estrogen-progestin combined? Does progestin, have an important role here? So what's the piece that's making a difference? And one of the most recent theories is the apoptotic effect of exogenous estrogen in a low estrogen environment versus endogenous estrogen increasing development of breast cancer. So there's also some time effect questions about heart disease. In WHI data that was looked at for age stratification, we had a decrease in risk for all the heart disease endpoints in the treatment group in women who were in the 50 to 59 age group. and those things increase in women in the 70 to 79 age group. So this whole thing about time effect, we've got meta-analysis that shows us there might be beneficial effects if we start therapy at the time of menopause. The WHI data suggested that that might be beneficial, and we have data coming to us in the next few years that will be very informative from the ELITE trial and the KEEPS trials as well. There are also new therapies that are coming on the horizon. It might be interesting to look at basidoxifene, which is a tissue-selective estrogen complex. There's some other estrogen agonist, antagonists that are being looked at. It'll be important for us to keep an eye on what those things might work. It's very important that we always individualize care. Look at what are their risks, what are the things that work for them, and where their own personal goals fit in relation to risks, benefits, and quality of life questions. I included in the handout some resources for you, and I want to acknowledge that several people always help me with my slide sets. Are there any questions? No questions? Which means I was awesome or it's lunchtime. Yeah. Great.
Are the answers to these questions different when we look at estradiol and
So she's asking about, because many of the big trials have been done specifically with Premarin and Provera, which is CEE and MPA, are the risks different if we use different types of estrogens? And the Papworth phase study, for example, used transdermal 17-beta estradiol and NETA, and their results were pretty much mirrored from the HERS study that was set up very similar to the HERS study. So we don't have enough data to say for sure. The ELITE trial is looking at that, and 2 years ago got a big extension. So we don't, any of us know the data yet, but as a researcher I'm thinking, well, if they got a big extension, it means that their risk parameters are still in a good space. And so maybe that's going to help us to learn a little bit more in the future. We just don't have concrete data to say that it makes a difference on dose, or that it makes a difference on route of transmission, or that it makes a difference if we use a different type of estrogen or micronized progesterone. There have been a couple studies using micronized progesterone that mirrored the same risks.